one of the foundational values in our group is that we center the voices of the people with whom we do the research, right? We don't do research to people or on people, we do research with people. And so our priority is to make sure that their voices are front and center. And we do that by sitting down and talking. Every time somebody that I know dies of a drug overdose, I question everything, right? Is what we're doing the right thing? Does it make sense? Should we be doing this differently? It's not working? Are we failing? Am I failing?
This is Brewing Better Health, a series from the School of Public Health at the University of Nevada, Reno, where every cup sparks connection and a healthy conversation. Join Dean Muge Akpinar-Elci each month for a cup of Turkish coffee as we pour insights into public health. Today, Dean Muge is joined by Dr. Karla Wagner, Associate Dean for Faculty Affairs, Foundation Professor, and Behavioral Scientist at the School of Public Health.
Karla, thank you so much for coming and joining us today for our Brewing Better Health video series. And I'd love to, just talk to you about your research and many other things. But whole idea with the coffee is just the conversation. Is again not the lecturing, not the boring stuff, but how we can personalize what we do. And I always start the one Turkish proverb, talking about how the one cup of coffee is remembered for 40 years. So as just starting the conversation, what is one conversation or moment in your life that much impact it happened and long-lasting impact made to your life?
I think I have two ways to answer this question, and one is about what inspired me to do the work that I do, and the other one is partially about what keeps me going to do the work that I do. Just this week, I received a card from a student who has moved on and has a child now, and she sends me a holiday card every year. And I got an email from somebody who worked on my team several years ago, and she's in New York, but she thought about us and about how the work that she did with us informed her current and future career. And it's, those things don't happen very often, but when they do, they're so impactful. And so every time I hear from a student or somebody who's moved through our group or who's graduated or somebody that I trained and I hear that they're out there doing amazing things, I'm just like, that touches me, I think, in that way.
Make sure, you are thinking that, yes, I'm doing the right things. That this is very satisfaction, but also assurance for us that, you impacted somebody's life.
And sometimes it takes a while. And so that's connected actually to my other stories. So the other thing that happened that stuck with me, that shaped everything I do, is a book that I read as an undergrad. I was an anthropology major in college. I was a physical anthropology major. I wanted to go to East Africa and dig up ancestral hominids with the leakies. And that's what I loved. I loved being in the lab with the bones, and that was what I was going to do. And I had to take one cultural anthropology class. I didn't want to do it. I put it off, and I took it, and it was so hard. It was taught by a medical anthropologist who did her work in Brazil. And it was so hard, and everything she was talking about was so foreign to me, and I really struggled. But she had us read a book written by Philippe Bourgois. And later, now 20 years into my career, I understand that Philippe is one of the leading anthropologists in my field. He trained with this instructor, Donna Goldstein. They trained with Nancy Shepherd Hughes, and she is one of a very important medical anthropologist. So she had us read this book that Philippe had just written. It was an ethnography of people who sell crack and live in East Harlem in New York. And reading that book that time changed my whole life. Seeing that perspective of an anthropologist and a medical anthropologist thinking about the social and structural factors that influence how people get involved in drug selling and how people get involved in drug use. And he set out to write kind of a political economy of drug use, but to me that book, it just made so much sense.
World.
It opened a whole new world.
Just to see. What's
so I didn't go to East Africa then.
What a switch.
I went to Long Beach and I worked on an HIV testing clinic, and then I went to Flagstaff, Arizona, and I worked on a study that at that time was one of the early studies with people who inject drugs. And then many, many years later, I ended up going to East Africa in a completely different context to do HIV work. But that, like, to me, like, that book is my cup of coffee. That book is what
you're changing the really small moments, change the many things and impacting the whole your career and your life.
What I come back to, and I tell people, if you want to understand me and why I do what I do, that book is required.
But what do you do now? Just tell me and tell us, just what is your job and and why you are doing it. You already explained a little bit, but what do you do?
What do I do?
A lot of things. I know. Picking is tough, but
I am a behavioral scientist, so I do my research from the perspective of somebody who thinks about culture and society and behavior. And then I use this public health lens that helps me think about systems and structures, all in a very kind of applied and pragmatic way to understand the factors that produce harms related to drug use, and then how we can intervene to reduce drug-related harms. So when I got into the field, my work was in HIV. And over the past many years, as the conditions have changed in the US, increasingly my work has been related to opioid overdose, heroin overdose first, and then fentanyl. And now a lot of the work that we're doing is related to methamphetamine use. But I would say the work is grounded in thinking about human behavior embedded within these social and structural constructs, contexts, and then like really applied, right? We are in my group trying to produce scientific knowledge that can be used to change people's lives.
That is, just also, just that I know that in the couple meetings you talk about your personal experience and particular experience and moment, how you realize how important this work is. Can you talk about that part a little bit?
Yeah, I might.
That is totally a safe place. I say that coffee is really just for the be in the moment, listen each other, and again, we have time.
Yeah. Every time somebody that I know dies of a drug overdose, I question everything, right? Is what we're doing the right thing? Does it make sense? Should we be doing this differently? It's not working? Are we failing? Am I failing? And I go through this cycle because in the field, when you do this work, like you know a lot of people. And over the past many years, we've had a lot of people die. But then I'm able to pull myself out of that, usually because I talk to my staff and I sit at our field site and I talk to participants in our research studies, and I remember that there are a lot of people out there who are living much better lives than they would have. And there are a lot of people out there who are alive because of the work that we're doing. I mean, every time somebody dies, it's such a big loss. And so we think about that, but then we have to pull ourselves back to remembering all the people who are alive because of the work that we've done. And when you sit at the field site and you talk with people, they come in and they say thank you. They say thank you for doing the work you're doing. Thank you for treating me the way you're treating me. And that happens a lot.
Sometimes people, they don't understand, but we question ourselves a lot as a scientist, also as an academician. We question ourselves, especially in public health. I can't talk to all our faculty what they do and how they do, but I guess is the main part is we always question ourselves also how we are doing to this job.
All the time.
right way to do it. But what do you see right now? Just there is a whole kind of misinformation, disinformation, and very difficult time to public health because we lost that trust and everything. And you are working with the very difficult communities sometimes to enter, to talk to them.
Yep.
Their trust is a big issue for them too because they don't know you. So how do you do it, and how you build that trust, and how you are making sure that they really getting to what you try to give?
We're scientists, right? And so we are supposed to ask questions and then conduct research to answer those questions, and science moves incrementally. And so sometimes, so we question our results. Things evolve over time. The field moves, and that is part of doing the work. But especially in challenging times, and when lives are at stake, that uncertainty can be hard. Certainly in the work that we do with people who use drugs, the illegal drug market is so unpredictable right now, right? It's so volatile and it's so dangerous. From day to day or week to week, people don't always know what's in the drug supply, and that's new. It didn't used to be that way, right? And so even talking to people who use drugs about that level of volatility and uncertainty, and how do you do your best to protect yourself in the moment, knowing what you know, but also knowing that there's uncertainty, I think that's one of the fundamental challenges of public health, right? How do we How do we do the best we can do and protect the most people with the fewest harms, given the uncertainty that always exists?
And also always stay behind the scene. Just because we are not a hero to...
Because we're invisible.
Yeah.
Public health, what do they say? If we're doing our job, you don't even know that we're here.
No one's here.
Yeah. But I think in some regard, the work that we do in my group and the work that we do with people is a little bit different from that because of this other thing that you're talking about, right? There's kind of community level trust, but then there's interpersonal relationships and interpersonal trust. And that's what I think that's part of what you're trying to get at here, right?
This is exactly, just because like a coffee and how this conversation, we have a relationship right now, and we are talking something, and we trust each other because we understand the perspective. I don't need to be scared about what's happening. Yeah. So that is how we can carry it to the communities.
And so when we do work with people who use drugs, we do the same thing. We sit and we listen and we share food and we share drinks.
Always food and drinks is the good thing.
Tell me what matters to you, right? One of the foundational values in our group is that we center the voices of the people with whom we do the research, right? We don't do research to people or on people. We do research with people. And so our priority is to make sure that their voices are front and center. And we do that by sitting down and talking.
Connecting with your research also, what does the research really tell about us? What is actually works when it comes to the reducing the overdose and the disease transmission? What is happening there?
Yeah. So the research, I'm going to answer this in two ways. One around HIV and one about opioid overdose. The research is quite clear around preventing HIV. Right? We understand that there are evidence-based prevention methods like using sterile drug use equipment, using condoms for sex, and that routine testing and initiation of antiretrovirals if somebody is positive or pre-exposure prophylaxis if somebody is negative are extremely effective. The next step there is really scaling those approaches up to really meet the needs of the population. The research is unequivocal. In terms of drug overdose, at the individual level, we have a very effective medication to reverse opioid overdose. which 10 years ago nobody was talking about. But since then, as a country, we've done a very good job of scaling up access to naloxone, or Narcan, which is the medicine it's an emergency rescue medicine. It's the medicine that can be given to somebody when they are experiencing an opioid overdose, and it restores breathing and saves lives. And there's no question about that. Again, it's a question of scale. How do we make sure that all the people who need it have it when they need it? And the other thing that we know is extremely effective in preventing opioid overdose is getting people on medication to treat opioid use disorder when they want it. Reducing barriers to accessing methadone or buprenorphine, offering it in as many places and in as many ways as we can to get people started on the medication as soon as they're ready is extremely effective at reducing risk for overdose death and reducing drug use. But again, it's a question of scale, and I think this is where public health comes in, right? The clinical data are very clear that these things work, and so as public health practitioners, our job is to think from a population level about how do we get this to all the people who need it, when they need it. Access with as few barriers as possible.
Yes. Coming back to your research and your evolving in your career, because with the public health is another part. Sometimes they confuse us with the like a regular academic people. We are, but in many sense, our research and our research question change according to location, where we are living, because our communities is our part of our mission. What happened in your career also, I just want to talk about, because you came to Nevada, and what changed or how you evolve your research?
Yeah, I think that's...
Or just according to day also, just because emerging things is changing in public health constantly. And
Right, I think that you're right. That is a hallmark of our discipline that is different than some other disciplines, that we are by design responsive to community needs. And so as the place we do our work changes or the needs of the community in which we do our work changes, we have to respond. So I got into this work, like I said, doing HIV prevention. I was working in syringe service programs in Los Angeles. And in about 2006, while I was doing my dissertation on HIV, they started an overdose prevention program. And they asked me, because I had skills in program evaluation, because I was trained in public health, they asked me to help them evaluate their naloxone distribution program. And that's what started the pivot in my career from HIV to opioid overdose. And at the time, it was heroin. And then since then, we've seen the emergence of fentanyl. And then when I came to Nevada in 2014, I was doing a lot of work around expanding access to naloxone. And I was talking to people here about what does our naloxone distribution infrastructure look like, and what are we doing, and how are we doing it? And people kept saying to me, and it happened when I talked to doctors, it happened when I talked to just friends in the community, it happened when I talked to drug users. People said, well, that's great, but what are you doing about meth? What are you doing about methamphetamine? That's cute that you're trying to work on opioid overdose, but our problem here, what we care about and what we don't have any tools to deal with is methamphetamine. And that really stuck with me. I gave a talk at Brown University in Rhode Island last year, and I titled the talk, Yeah, but what about meth? Because it was so clear to me that that was the thing that we needed to talk about in Nevada, and we didn't know how to talk about it. And since then, if you look at the national data, stimulant use and methamphetamine use especially has gone up across the country. So that was another kind of newer pivot in my work, was really looking at methamphetamine use and the impact of methamphetamine and fentanyl co-use. So I have several projects now where we collaborate with people across Nevada, but also in New Mexico and in other places where methamphetamine use has been highly prevalent for a very long time. And in my studies, it's something like 98% of the people we recruit use methamphetamine, and most people use multiple substances. And so that didn't come from my head as a scientist, that came from the people saying, this is what we care about, this is what we need, this is what's going on in our lives. Can't you do something about this? And when the people ask you, can't you do something about this? You know what I really need is an intervention to do this, or what I really need is the skills to address this phenomenon. I think we're really lucky as public health people because we get to do that. I get to say,
we need to be flexible
yeah,
and adaptable because everything can change. What COVID happened, just whole world changed 1 second. If you are not flexible and adaptable, then you lose it. And that is the problem with sometimes people. They are not thinking public health that level. They are thinking like we are like an irregular discipline, but we are different because we need to adapt as quick as possible.
Yeah, I think that comes from our orientation, our community-facing orientation, and also the very applied and pragmatic perspective that most of us have.
And also impact, just that impact, because everything is, we are not just enjoying to do our research because personally we like to do it. Everything is impact. If you are not turning to your research to practice, then unfortunately is not really, if it's not applicable for the community, sometimes you lost to that connection. And again, with the science and the sometimes issue is you are not making to that connection and just we are losing the trust constantly, that part.
I love my research. I love writing papers. I love writing grants.
Of course, we are academicians. We like to write
I love
paper.
that part of my work, and it brings me so much joy. But when I can then bring that back to the community and say, here's what we did because you asked for it, that is so rewarding, right? It is very rewarding for me to get a grant or publish a paper. But the more rewarding part is to bring it back to the community and say, here's what I think we should do next. And here's what we did with what you suggested to us. What do you think? And then they sit down and they mark it up and they say, don't do it this way, do it that way. And it would be better if you did this. And then we workshop it.
Exactly. And also I know that your research impact the legislation too. And you changed something in the whole state.
Yeah.
So just tell me about that one. It's a very exciting piece.
Yeah, so when I moved to Nevada, I moved here in 2014, and they were preparing for the 2015 legislative session. And across the country for the past, 10 years before that, states were state by state passing legislation to facilitate access to naloxone, the rescue medication for overdose. And when I got here, people were engaged in that conversation, and because I was here at the School of Public Health and because I had this expertise, I got involved in those conversations. I worked with the team that drafted the bill. I testified in front of the legislature with a group of people from the community, and they passed what was, at that time, one of the best pieces of naloxone access legislation that existed in the country, one of the most comprehensive. And that was such such an opportunity, right?
But again, just everything needs to connect. If you are doing the academics work and the science and the research, that needs to connect with the community. When the community buy in what's happening, needs to connect with legislators and policy making, because impact is that way more meaningful.
Yeah.
But again, just today with over the Turkish coffee, we are talking about this one because I really want our followers also see who you are. You are the person, and you really care about what you do, but you care about the people, not just you care about your research. This is everything. This is the people and how you do it. I have another question. Always, that is the issue. In the many sense, why is it important to view the drug use as a public health issue, but not just a criminal or moral issue?
That is the big question, right?
Because I want the people also connect with this issue and the problem more personal level. Doesn't matter. Many families impacted and affected about this one. But all of us, I have very young adults, kids in my life, just
Yeah.
my kids. And it always is scary as a mother, scary because you don't know when they get the exposure or what will happen. So I really want to have your views, just as a normal families, why we need to care about this one?
That's such a big and important question. And again, I can see a number of paths to go here, but I think it's really tempting and it's easy to think about drug use as a choice, as a moral failing. And the solution to that, if that's what you think about drug use, then the solution is make better choices, stop doing what you're doing, be a better person. But everybody knows somebody who uses drugs.
Yes.
And this wasn't the case when I started my work in 2006. But at this point in my career, when I walk into a room and I talk about overdose prevention, everybody knows somebody who's died. When I talk about this in classes, I have students lining up after class to tell me about somebody in their life or somebody in their family. Like, this is an issue that touches everybody.
Everybody.
And when you know that it touches you and the people you know, it gets a lot harder to create that social distance and to other people.
This is other people's
right.
problem.
It's not other
It's
people's
not
problem anymore. It's our problem.
our problem.
And the public health perspective helps us think about upstream causes of drug use, right? It's not just about somebody making a bad choice, but what's going on at home and what's going on with their trauma history and economics and
Mental
poverty
health,
and mental health,
health,
right? And
social health,
and access to
social
care.
Exactly.
Access to health care, access to social isolation. So we talk to people in our studies who use methamphetamine because they have chronic pain and they aren't getting their pain treated, who've had terrible exposure to trauma. We just learned that something like 98% of the people in our study have at least one event in their life that would qualify as a stressful or traumatic life event. 98%
That is a huge number.
of our participants. And
So there is a reason actually why it's happening. Isn't that just
Yes.
I want to just out of blue, just I go and just buy it. But there is a couple reasons in there.
Right. And so when you can frame it that way, when you think about it from that perspective, then there's a lot more you can do to reduce
can
the
support
consequences.
these people.
Right. By fostering social connection, by lowering thresholds to
Social
access.
connection.
Yeah.
Again, over the
This-
coffee. Just why we say that, just a coffee, you don't grab to go. Just
Right. It's
drink with the
about
people.
connection and meaning and purpose, and it's about having access to fundamental things like treatment for opioid use disorder and sterile injection supplies and naloxone and food. And so this ties back to what I was talking about at the beginning, the book In Search of Respect. He set out to write a political economy of drug selling, right? When you understand the social and structural conditions in which people are living, things that maybe from another perspective seem irrational become very rational. And when those choices become rational, when it makes sense to you why people are doing what they're doing, then you can design interventions and treatments that actually work for people. And that, to me, that is what public health does.
Yeah, and just making just a criminal or moral, you are stigmatizing the people. It will be more problematic for the community actually, because we need to catch these people. We need to prevent the problem, and community will benefit more from this part. So
Yeah.
that is a very important piece.
The threat of being incarcerated doesn't keep anybody from using drugs, but it does increase their risk of death significantly, right? It disrupts social connections. It makes it harder for people to get jobs. It disenfranchises people. It separates people from their families. It disrupts their housing. And so when people get released from incarceration,
marginalizing them, so they are not in the community, and you cannot help them or control what's happening. Then is getting worse. Problem is getting worse, and how we can help the people. That is important. But over the coffee. We almost finished our coffee, and I just wanna ask, what gives you hope for public health for future?
Our students.
Next generation.
Yeah, I just talked to somebody today about a new study, and he was so excited. And he was telling me that he was very proud of the work that he did over the summer that laid the foundation for this, and that it was his first big project, and he wants to keep going with it. And like the energy and the enthusiasm that people bring into the field is what's gonna do it. It's what's gonna keep us going.
No, but thank you so much, really joining me to Brewing Better Health, and I look forward to your new studies and the new work. But I know that is the main part is how you care about the people, and this is the most important part for our school, who we are actually. Thank you.
Well, I appreciate that, and I want to say that this is not a one-woman show. Right? The work that we do in my group, I have a team of 8 full-time staff that work with me, and we have students and we have volunteers, and this isn't the Karla show. This isn't about me.
But public health is the teamwork.
Yeah.
And the collective understanding of our work.
Yeah, and I work with an amazing group of people who bring their own perspectives and their own ideas, and that diversity of thought is also really important to what we do.
Thank you for your amazing work. Thank you.
Thank you.